Good afternoon. This is the Arizona Department of Health Services. This is the healthcare provider webinar for COVID-19. This is a repeat webinar to a series that was given last Friday. And my name is Dr. Nick Staub. I am the Medical Director for the Bureau of Epidemiology and Disease Control here at the department. And without further ado, we will get started here. So again, our agenda for this webinar is to review the outbreak to date, review how you can prepare as a healthcare provider, what you can do, and at the end, we will have an opportunity for you to post questions into the chat box, and we will try to make our way through as many of those questions as we can before the end. So again, a brief review just to help put some context to the current outbreak and recommendations that we are giving. So this outbreak began at the end of December 2019 in China with a cluster of 30 patients with pneumonia of unknown cause. At the beginning of January, that cause was identified as a novel coronavirus. By the end of the month, there were over 9,000 cases reported globally. Here in the United States, in an effort to contain the outbreak at its source, we initiated screening of returning passengers at U.S. airports. The first case of the novel coronavirus was detected in the U.S. in Washington State on January 21st. And in Arizona, we confirmed our first case on January 26th. In February, the WHO renamed the disease COVID-19. And by the end of February, there were 51 countries reporting cases and over 80,000 cases counted. In February, the US reported its first possible case of community spread. In March, the WHO declared a pandemic just a couple days ago on March 11th. And there are currently more than 110,000. My latest count that I saw was just over 130,000 cases reported worldwide. So again, here in Arizona, in January, we had our first confirmed case of COVID-19 in a person who had recently traveled to Wuhan City, China. In February, all the close contacts of the confirmed case were contacted, tested, and tested negative. And the case eventually tested negative as well and was released from isolation. Now in March, Arizona is reporting more cases, some travel associated, and some with no known exposure. Case count as of March 11th here in Arizona is 9 cases. There are 938 reported in the US, excluding those who have been connected to cruise ships. And just this week, Governor Ducey declared a state of emergency here in Arizona. This slide shows the distribution of cases as reported by the World Health Organization, which gives a good sense of the global spread of COVID-19, as well as those countries that are seeing increased transmission. So, COVID-19 is the name of the clinical syndrome caused by infection with SARS-CoV-2, this new coronavirus. We know that coronaviruses are a very large family of viruses, generally causing infection in animals. However, we know that occasionally those infections in animals can be transmitted to humans, and that then human-to-human transmission can occur. In general, coronaviruses in humans cause a mild respiratory disease, very similar to the common cold. Previous outbreaks of novel coronaviruses include SARS in 2003 and MERS in 2015. We know that endemic human coronaviruses cause about 15 to 30% of upper respiratory tract infections each year. And generally, endemic human coronaviruses cause more severe illness in neonates and the elderly and those with underlying illness. When person-to-person spread has occurred with novel coronaviruses, as it did with MERS and SARS, it is thought to happen mainly by respiratory droplet transmission, and it occurs when an infected patient coughs or sneezes. This is very similar to how influenza and other respiratory pathogens are spread. This is a phylogenetic analysis of the novel coronavirus there in the center in the red box, highlighted in red. And of note is how similar it is genetically to the SARS coronavirus. And a lot of our initial investigations, both into therapeutics and immunizations, have revolved on its close genetic relationship to SARS coronavirus. So what do we know about COVID-19 and SARS-CoV-2 to date? There's still a lot of questions, as there always is with a novel infection and a novel virus. We know that it can cause a wide range of symptoms from very mild to severe disease. Those symptoms include fever, cough, and difficulty breathing, which is very similar to flu, which is still circulating in our community here in Arizona. Information so far suggests that most COVID-19 illness is mild, and this is based on case series and the large number of cases that have been reported out of China. A report from China suggests that serious illness occurs in about 16% of cases, and older people and people with underlying health conditions seem to have the most severe outcome, including patients with underlying heart disease, lung disease, and diabetes. This was a report from Lancet that looked at an initial case series of 99 patients who were admitted to the hospital in Wuhan City, China. They reported demographics which showed mostly older, predominantly male patients with chronic medical conditions in about half of cases, and 23% of these cases required admission to intensive care, and a total of 11% of this 99 died. In terms of what they presented with initially, again, as we have reported and as our case definition has shown, patients are reporting with predominantly with fever and cough, less with shortness of breath, muscle ache. 75% of this initial group were presented with bilateral pneumonia on imaging, and this has been consistent as the outbreak has spread and more imaging reports have been published. 75% required supplemental oxygen, but only 4% required mechanical ventilation. This is from a report from the CDC, from China CDC, that looked at a total of 72,000 patients who were reported with COVID-19. Of that, 62% were confirmed cases with laboratory confirmation. There were 1,000 deaths reported in this patient population, which gave a case fatality rate around 2.3%. And the peak of the epidemiologic curve in China was placed around January 23rd to 26th. So we now know that the virus is spread person to person via respiratory droplets and requires close contact in order to occur. Close contact by CDC definition is within 6 feet of another person. There's currently no FDA-approved medication to treat, and there's no vaccine to prevent infection with SARS-CoV-2, the virus that causes COVID-19. So, in light of all that, what we are recommending from the state health department and local health departments is that there are everyday measures that the public can take and that you can encourage as healthcare providers to prevent infection. These are our non-pharmaceutical interventions, or NPIs, and they include proper hand washing, covering your cough and sneeze, and very importantly, staying home when you are sick. There has been a significant amount of change in guidance related to a change in the way that we are approaching this outbreak. So as is the case with many outbreaks, at the beginning, the goal is to contain the virus at its source. So we call that a containment phase. As that outbreak gets out, as the infection gets into the general population and we see sustained community transmission, we then move into what we call a community mitigation and preparedness phase. So our guidance has changed very much from what you initially saw as intensive screening, case contact investigations, and then instituting quarantine for those who are exposed to known cases and isolation for cases who test positive. And we are now moving into a different phase of mitigation. So this slide, again, just goes over those containment strategies, which we are transitioning from, and to mitigation strategies. So again, this is the social distancing that we have been trying to communicate, how to avoid crowded public places as much as possible, kind of just stay to your smaller home communities, and then also those non-pharmaceutical interventions, including hand washing. So what can you do, and what are we asking of our community healthcare providers? Most importantly is that everyone stay informed about the local COVID-19 situation. So our website, which will be, a link will be listed here in this slide set, to the Arizona Department of Health Services website, we believe is a great resource. We take a lot of information that comes down to us from CDC, guidance from CDC, and kind of distill that into a format that we think is applicable and relevant to Arizona healthcare providers. Again, the signs and symptoms of COVID-19 have been pretty steady. It's always been fever and cough, but what we're really looking for is that you stay up to date on diagnostic testing guidance, and then the case definition, which again has been relatively stable in the last couple of weeks. It's really diagnostic testing and availability of treatment that we are looking for you to stay up to date on. We ask you review your facility's infection prevention and control policies, and that you know to report a suspect COVID-19 case or exposure within your facility to the appropriate local public health authority, either your county or tribal health department. We think it's really important as healthcare providers that you're communicating with your staff, again, providing good information about COVID-19, planning for a potential surge in your patient population and how your staff will handle that, reviewing preparedness plans. So most practices have a plan already in place for seasonal influenza or pandemic influenza, and those plans can be used to deal with COVID-19. And then review sick leave policies with your staff. Again, it's very important as part of our mitigation techniques that if you are sick, you stay home. And so we need employers to enforce that by having sick leave policies that allow staff to do that. A lot of questions coming to us from healthcare providers. Okay, so what do I do when a suspect COVID-19 patient arrives at my clinic or calls to be evaluated in the clinic? So first is just to do that assessment of symptoms. Do they fit the symptomatology of COVID-19? If they do, then that patient should be isolated as soon as they present to your facility with a face mask, and then placed into a private room with the door closed if available, or at least a part of your facility where they can maintain at least that 6-foot distance from other people that they are near. Still important to ask about travel from areas experiencing transmission of SARS-CoV-2. However, as we see increased evidence for sustained community transmission, the requirement for a geographic epidemiologic link is becoming less important. And then ask about contact with possible COVID-19 patients. So again, when we were in that containment phase, this was a little more critical. Now that we're seeing the infection in our community, this will not be as important in terms of your screening questions. So if you have a patient who's fitting the clinical criteria for COVID-19. That is the current CDC recommendation for testing. Various facilities and healthcare groups are developing algorithms for testing that may include, and we would recommend testing for seasonal influenza still. It may include a comprehensive respiratory viral panel if you have access to that. But once you have those ruled out, those other common viral infections, then general healthcare providers out in the community can submit testing for COVID-19. And so what I have done here is put links to some often used labs who are now accepting specimens for COVID-19. They include LabCorp, Quest Diagnostics, and ARUP most recently. We know that Mayo Clinic is coming online here shortly if they have not. And then Sonora Quest here in Arizona will be sending their specimens that are submitted through them to Quest Diagnostics. We are still testing for COVID-19 here at the Arizona State Public Health Lab. However, our criteria for testing are a little more stringent than those at the commercial lab. And so I just have placed those here again for your reference, but they really require symptomatology and either travel history, contact to a known laboratory positive COVID-19 patient, or admission to the hospital with severe disease without an epidemiologic risk. So again, we are still accepting specimens here at the state lab, but those have to be approved through your local health department and then through our state health department before they are submitted. However, for submitting specimens to those commercial labs, there is no requirement that the local or state health department approve that. So again, we encourage testing for common viral pathogens. Again, we are still seeing significant influenza and RSV cases being reported, so that's still important to test for. Consider the role that chest X-ray or chest CT might play in helping you distinguish COVID-19, especially for those patients who are admitted to the hospital. Contact local public health department to arrange for testing, again, only if you are seeking testing through the state public health lab. And then the specimens that are being tested currently include sputum, oropharyngeal, and nasopharyngeal swabs. That guidance has just changed from the CDC, which is recommending just the nasopharyngeal swab. If you collect both an NP and an OP swab, they can be combined and placed in a single container and be submitted for testing. That may increase diagnostic accuracy. But again, the current guidance that is just out yesterday is to use just a single NP swab. And then submit those in standard viral transport media. If you're using a commercial lab, you can order both the swabs and the media through those systems. Just a reminder, this is what they look like. And this was from last week's webinar when we just had the announcements, but again, now they have their lab directories updated with all the information you would need to submit that specimen through those labs. All right, treatment for COVID-19. There is no FDA licensed vaccine or treatment for COVID-19, and care is supportive as it is for other viral respiratory infections. Remdesivir is a RNase polymerase inhibitor that has been used in limited cases. It is currently undergoing clinical trials in China and here in the United States at 4 sites. Compassionate use is available by direct application to the manufacturer Remdesivir Gilead. There is a vaccine that is under development at the NIH, and the best estimate for rollout or kind of widespread availability of that vaccine is still roughly a year away once clinical trials have been completed. And this recommendation against using corticosteroids came out of some early evidence in China that there was really no clinically significant improvement in patients who were treated with steroids. Disposition, I think, is a very important thing to talk about, as many of these cases of COVID-19 are mild or moderately ill and may not require that they be admitted to the hospital. So if a patient is not meeting inpatient admission requirements, then they can safely be sent home for home isolation, self-monitoring. Again, the local health departments are no longer able to actively monitor each of these positive patients. So they should be advised to self-monitor at home in isolation, follow our social distancing guidelines, and be given careful return precautions in case they become more ill at home. We have developed some home care guidance that is available on our website and here. And again, it's just talking about the same social distancing techniques and NPIs that we have been recommending since we've moved into this mitigation phase. These are important to review with each of your patients when you see them, or if you're triaging over the phone, to make sure that that staff in your practice who's doing those triage has this guidance in front of them so that they can give good information to your patients. We developed a provider checklist, which again just goes through those areas that we've already gone through about how to appropriately identify patients, implement effective and appropriate isolation, how to contact your local public health department if you to report a case, or to coordinate lab testing if you believe they meet those criteria for testing at the state health lab, what specimens to collect, and then again, what education to provide to healthcare providers. A couple slides here on just educating patients. Again, it is going to go over those same social distancing and non-pharmaceutic interventions. We, again, because of ongoing spread of influenza, would recommend that if a patient has not already received this year's annual influenza vaccine, that they still would be eligible to receive that. Again, a good idea would be kind of some proactive communication with your patient population, including to instruct them to call ahead if they have respiratory symptoms. If you have the opportunity to do telemedicine, that's a great option to try and, again, mitigate this, the spread of this disease. Review visitation policies if you are a provider at an inpatient facility to make sure that we are limiting visitation and especially restricting those visitors who exhibit symptoms consistent with COVID-19 from visiting your facility. Infection control, this has changed kind of obviously from the beginning, where we had recommended airborne isolation. The isolation is now recommended to be droplet precautions, and this week the CDC came in line with Arizona in making those same recommendations. So again, the precautions to take are standard contact and droplet precautions with eye protection. Obviously, hand hygiene is critical. PPE includes gloves, gown, medical masks, and eye protection. And if you are doing an aerosol generating procedure, which includes intubation, extubation, bronchoscopy, among others, the recommendation is then to institute airborne precautions, use that N95 mask or other respirator type, and if available, perform that procedure in an airborne infection isolation room. I will acknowledge at this time that we are very aware of the shortages of PPE that exist out in the community and the limitations that this is placing on our healthcare providers feeling comfortable performing the testing in their clinic setting. So Currently, our local health departments, our county health departments are collecting information on shortages in the community. So if you are experiencing that in your practice, we would highly recommend that you report that to your local county health department. They are not sitting on a cache of PPE at this time that they can readily distribute, but we are collecting that information here at the state. And as we have declared a state of emergency here in Arizona, that has opened up opportunities, and with funding that has come from the federal government to try and obtain that PPE and distribute it in a way that can improve testing out in the community. So we are actively working on ways to get that done as soon as possible. Having our healthcare providers doing the testing in their clinics and in an outpatient setting is really a critical role in order for us to increase the amount of testing that we are able to do and really get a better sense of how this infection and how this outbreak is affecting our community. In terms of managing visitor access and movement within the facility, we do have some guidance and recommendations up for that for those inpatient facilities. We are asking that you monitor and manage the ill and exposed healthcare personnel. And I will talk a little bit more about that in a moment here. Train and educate healthcare personnel on the infection control practices that they need to be following. Address environmental cleaning. As possible, dedicate medical equipment to individual patients. Follow your routine environmental cleaning and disinfection procedures. There's really nothing about disinfection that should make you do any extraordinary environmental cleaning. Just make sure that you are following those practices and procedures that you have in place. You can use a bleach and water solution to effectively clean, which is a 0.1% solution of that dilution of 1 to 50. There's also a long list of EPA registered products that you may use called List N, and it's linked here. The long list, and I anticipate that many of the products that your facility, your office may already be using are included in this list. So also recently changed is our assessment and handling of exposed healthcare personnel. So any asymptomatic healthcare personnel who may have had exposure to a COVID-19 patient can continue to work in a healthcare setting after, so they can continue to work in a healthcare setting as long as they're asymptomatic. The CDC has added additional language that, if possible, you should find an alternative healthcare provider who has not been exposed to a COVID-19 patient to take that person's role. Again, as we all know that there are limited personnel in the healthcare system, I think it's safe to say that we may get to a point where we're just really looking and monitoring those exposed healthcare workers for the development of symptoms. And I would advise you, if you have facility infection control practitioners, to talk to them about what that monitoring would look like, and also be very clear to your exposed healthcare providers that as soon as they develop any concerning symptoms, that they remove themselves from the healthcare environment and report that those symptoms to their occupational health program or supervisor. Okay. This is really rough draft, but I thought it was really cool, and so I wanted to share it with you guys today. And then we're working on making this prettier. But this is some information that we hope in the near future to be spreading wide around Arizona, and it's how we as a community, as the state of Arizona, can respond to respiratory illness. So what we've done is just develop a simple chart here that compares COVID-19 to a common cold and to influenza, and really demonstrating for the public and for you healthcare providers who are communicating with them that much of what we have always recommended for seasonal colds and flus is the same for COVID-19. And in an effort to encourage some of these non-pharmaceutical interventions, washing your hands, social distancing, not going to work when you're sick. These are really things that we should have always been doing, but maybe had gotten a little lax in doing. And so we want to develop this campaign as a way to message to the public. Of course, the one thing that you can do for flu that you can't do for COVID-19 or cold is get vaccinated. Obviously, we always want to encourage that. And then we made this specifically for Arizona providers, for you, to really encourage you. You know, a lot of employees, a lot of different workers across the state might be able to work from home for a couple weeks, but we know that you healthcare providers can't, and we're in the same boat with you. And so we want to encourage you to step up and really take on an active role in helping us to deal with this outbreak. So again, we go over here how to diagnose the infection. And again, we will be changing this because the new guidance from CDC is just for the NP swab. So COVID-19 and flu, it's the same swab. How do you treat an infection? Mostly supportive care, except for we do have antivirals for flu. How do you counsel patients about the prognosis? So it really is the same, whether it's COVID-19, cold, or flu. And I think you really need to look at those risk factors in your patient, older age, underlying healthcare, underlying health problems in order to better guide your discussion about prognosis. How do you counsel patients about preventing spread? And again, we wanted to highlight here, it's the same NPIs that we use for cold and flu. And then what about personal protective equipment? This is where things are a little different. And we know too that eye protection has been another difficulty out in private practice and outpatient practice. But again, please, with regards to PPE, do let the county health department know if you are experiencing shortages, what those shortages are, and we are working to address that. This is a slide of additional, we have additional resources following. So this is the link to the CDC coronavirus or COVID-19 website. This is a link to the website we are maintaining here at the Arizona Department of Health Services. If you have not already signed up for the Arizona Health Alert Network, this is the way that we here at the department get out our urgent messaging to healthcare providers. You do not need to be a healthcare provider to sign up at AZHON. So you can encourage practice managers, other people involved in your practice to also be signed up here. It's our best way of messaging in kind of an urgent fashion and changes that we want you to know. We also have the IDAZ app that's available wherever you get your apps for your smartphones. The same messaging that goes out on the Arizona Health Alert Network will go out on the app as well. It also has a variety of other resources for you. And here are a bunch of links to resources that we have found helpful both in making these slides and in communicating with healthcare providers who have been in touch with us in the last few weeks. So now we will go to questions from the some odd thousand of you. This is just one, before I answer questions. So there has been established a phone line, a hotline through the poison control system, so that if you have questions, we are directing first calls to go to that hotline where they can triage calls and then send them to the local health department as needed. So we will update this slide before we post it. And then we'll also, we can add it in the chat box here. Okay. All right, let me just start with this question. I'll just read it. If we saw a patient with fever last week who worsened this week and is currently in a hospital, no confirmed COVID-19 yet, but is being tested, should the provider and MA be isolating? So hopefully I answered this. So for exposed healthcare personnel to COVID-19 patients, the recommendation is for self-monitoring or monitoring through your occupational health system. And that's monitoring for the symptoms of fever, cough, congestion. As long as the healthcare worker is not exhibiting those symptoms, they can continue to work. If at any point they do develop symptoms, they need to remove themselves from the healthcare setting and self-monitor at home. Reach out, obviously report that to your supervisor or occupational health, and talk to your personal healthcare provider for more information on whether or not you should be treated. So again, there's a question about whether or not these slides will be available in a recording. All of that will be available. Give us a couple of days to turn that around, and we'll have it available on our website. So there's a question about whether we consider children on biologic agents higher risk. Consider anyone who has any sort of is in any sort of immunocompromised state to be at higher risk. So whether they're children or adults, they should really be encouraged to follow those social distancing guidelines. We've also recommended that for specific underlying health conditions and to identify certain risk factors, that those patients be in contact with their healthcare provider, either specialist or general doc, in order to discuss their risk factors.
There's a question here about where patients can get tested for COVID-19. So in great news, like Nick had said, lots more commercial labs are coming on board for that. So including the state lab, which, like we said, has some sort of more stringent sort of criteria around it, the amount of commercial testing is increasing. So at this point in Arizona, we've got LabCorp, ARUP has started, I think, as of yesterday, Quest Diagnostics, and that seems to be continually increasing. So,
and in response to what we've heard from providers, we know about the shortage of PPE. We know that there's some misgivings to collecting specimens in the clinic setting. We're actively working on other available sites to obtain testing, and we'll get that information out as soon as we are able to. Currently, both LabCorp and Sonora Quest are not doing testing at their patient care centers, so you have to be tested through a provider at this time. But again, we know the difficulty that's out there, and we are working to come up with solutions to increase testing. We all want increased testing.
Let's see, do you recommend that healthy, non-patient facing, so maybe admin staff, be asked to work from home? And so I think at this time we're not doing a sort of across the board recommendation that, you know, we move to teleworking, but I think it's a great consideration. If you've got individuals who don't have to be in the office, that you can have telework, especially those who may be at high risk, this is a great consideration at this time.
There's a question about how long is someone still contagious once confirmed. So again, back to this being a new virus, we don't know that, and we don't have, at this time, we don't have serology testing to look for kind of the long-term serologic markers of contagion and infection. So we are relying on epidemiologic studies that have shown that you are most contagious when you are acutely ill. So we are using those acute symptoms as the period of highest contagion, and a lot of our guidance revolves around that.
So do we know what healthcare professionals can expect if they feel ill and have no sick time? Are there guidelines around this? So from our perspective here at Public Health, we are encouraging all employers to consider what their sick leave policies and procedures look like, and ensure that based on the public health recommendation that those who are ill not come to work, that they create policies and procedures that help support that. So that is what public health is telling businesses and other employers at this time, is that we need to really ensure that we've got good, flexible sick time or sick leave policies in place.
There's a question about an FQHC and if it's possible to get testing kits to perform testing ourselves. We want everyone to feel like they can test themselves. So whether you're an FQHC or other type of practice, reach out to whichever lab you use and ask for testing supplies. They will be able to deliver those testing supplies so that you can test them. The other question that might go along with this too is covering the cost of testing. So as you may have heard out in just the public media, there is a significant effort from lawmakers to ensure, and it was part of Governor Ducey's state declaration, that the cost of this testing not be passed on to the patient. Again, there's still some effort to go into those details, but this test should come free of charge, the test, to patients. That's still pending. The question about what type of mask is recommended. So again, the appropriate PPE, personal protection equipment for a provider caring for a suspect COVID-19 patient or collecting a specimen on a COVID-19 patient is gown, gloves, mask. That's just a standard medical mask, not a respirator, not an N95 type mask, but just a standard medical mask, and then eye protection, which includes goggles or face shields. The N95 mask is only needed in the setting of an aerosol-generated procedure. And again, we do not consider specimen collection for standard COVID-19 testing to be an aerosol-generated procedure.
We've got a question. I work at Crisis Response Center, and many of our patients are homeless. If a homeless patient tests positive for COVID-19 and is advised to go into quarantine, what are the options available? So we are stepping away from quarantine more and more as we continue to see community-wide spread. But I will tell you that we are doing our best right now to coordinate with shelters and other areas that might be receiving individuals who are experiencing homelessness. And we're working with them to try to give them the best recommendations. We all know this is going to be a very tricky situation, but we're trying to work with them to give them the best information we can about how to best ensure that these individuals can do things like social distancing, can do things like proper hand hygiene and cough hygiene. It's certainly a tough one, but we're working with them right now to kind of come up with strategies to handle this.
There's a question about the fact that many patients are presenting with these symptoms these days. Is it really necessary to test everyone who presents with fever and cough for COVID-19 if they test negative for other common viruses? The decision to test is, by CDC guidance, is very clearly in the hands of the clinician. And I think you also need to consider this is a test for a disease that does not have treatment or a vaccine available. So we want as many people to test as possible because that gives us a good sense of public health about the burden of disease in the community. But the decision to test should ultimately come down to a discussion between you and the patient or you and the patient's family and what you're going to do with those test results. There's certainly no mandatory testing for anyone with a fever and cough. So just keep that in mind when you're considering testing and what you're going to do with it. In terms of reporting to your local health department if you are testing, so again, if you are submitting a commercial test, you do not need to get approval for that testing through the health department. We are collecting through lab reporting. We get all reported positive tests through those labs are reported directly to the state. Technically, given that this is a novel infection of public health interest, there is a reporting requirement to the state of any cases. So we're asking for you to report, but don't tell anyone in my department I said this, but we want you to test and take care of your patients right now. That's the priority.
We've got a question, and I think Nick covered this a little bit, but about where patients need to go for specimen collection. So at this time, based on how the commercial labs are going about this testing, the specimens do need to be collected at a provider's office or by a provider, so that we currently it's not possible to be sending to like the testing areas.
There's a question about not having PPE. It says that you do have masks, but no N95. So again, N95s are only necessary for aerosol-generated procedures. So if you're not intubating someone or bronching them, go ahead and just wear that medical mask, grab that swab, and you can do the test. So again, there's a question here about risk factors, underlying health conditions, diabetes in particular. I think if you are seeing a population that is at high risk, whether they are over the age of 60 or have some underlying health condition, just be prepared to discuss the guidance, which is, home, which is social distancing, staying at home, staying out of large congregate settings, washing your hands, avoiding sick people. So all that stuff just is so much more important if you are at higher risk. So being able to discuss those risk factors and really encourage that guidance with your patients is what we are asking of you. There's a question, are all steroids off the table for treating? So again, the case series and the reports out of China were on severely ill people, noting that the use of corticosteroids was not beneficial. That being said, I think when it comes to severely ill patients that you may be taking care of in an intensive care unit, those clinical decisions and what you choose to use to treat are your decisions to make. So nothing is absolutely off the table, but again, these are just the reports that we're getting out of the experience with this disease, a novel disease from China.
There's a question here about the dental industry and specific recommendations that we have for the dental industry. And I think it really sits around what, if you guys are doing what you would say is aerosolized generating procedures, we have our recommendation here of using things like an N95 and going airborne. I imagine that you have some policies and procedures that sort of sit in general for your practice or around cold and flu season in general. So following those and ensuring that we're adhering to those, I think is really going to be the way to go forward with that.
That answers this question. There is some guidance out from the ADA, but it essentially says just that. Follow your usual practices for flu. If you have a patient, you can screen your patients as they come in for clinical symptoms, and if it's not an urgent procedure, you can ask them to reschedule when they are well. For assisted living homes, can we restrict visitors completely? So we cannot give that guidance. What we have done is give guidance on how you might go about both screening visitors and then talking to both the people who are living at your facilities as well as their families. So I would refer you to your local kind of licensing authorities and stuff in terms of whether you can absolutely restrict people from visiting, but certainly putting in strict screening guidelines and other restrictions are certainly something smart to think about. Do I have recommendations for providers who are in their 70s working in a geriatric emergency department? So I have the same recommendations for you that I have for the general public, which again is you're at increased risk not only because of your age, but because of your occupation and ongoing exposure. So be very careful about following appropriate isolation guidance, using the appropriate PPE, wash your hands, cover your cough. If somebody's sick, if you are sick, get yourself out of that healthcare situation. So again, I think it's just an additive number of risk factors for you to consider. Is bleach safe for pregnant women to use during this outbreak? My best understanding of bleach, this is a little outside of my knowledge, is that bleach is safe. So we can touch base with our environmental health people to get the straight answer on that.
Let's see. I'm a provider working in an outpatient surgery center in Cottonwood. I've suspected infected patient. What do I do? Do I call the local hospital, which is in Verde Valley Medical? I think, yeah, great. Open lines of communication, knowing where to send patients, and making sure that we're communicating properly is going to be key. I think also the question of, you know, do they need additional medical care at this time or not is also one to consider.
There's a comment here about if someone is suspect for COVID-19, do you have the exposed family members stay home as well? Again, and I'd like to turn back to our transition from containment to mitigation in terms of what our recommendations are. So in our containment phase, we did careful case contacts. We were testing everybody who had contact with a known case, and while they were pending their results, they were kind of instructed to stay at home and quarantine at home. Now that it's just as likely that someone catch this infection from being out in the community as it is at home, the guidance to restrict contacts to staying at home while they're asymptomatic is less strict. So again, we're looking at a lot of these decisions being driven by whether or not a person is symptomatic or not. And then if they are known contacts, they just need to know that and then be monitoring for those signs and symptoms that they're developing.
Let's see. What is the suggested level of PPE for hospice workers, home visits, et cetera? So I think for all of our healthcare workers, we're really kind of sitting in the same zone. So we're rocking contact standard and droplet precaution with eye protection, unless you're doing an aerosolized generating procedure on an individual who might be a suspect or a confirmed COVID-19 case.
And that's for a symptomatic patient, right? So that's if the person you're visiting and working with has symptoms of COVID-19. If they don't, then you just take whatever standard precautions you take in your line of work. Certainly, Tyvek suits are not on the board for anyone. So if you have a Tyvek suit, do something fun with it, but don't use it in practice. What is the turnaround time for Quest or LabCorp tests? So including transport to their facilities. So neither of these labs are testing locally. They all have remote testing facilities out of state. So that's why their turnaround time is about 3 to 4 days. Here at the state lab, our turnaround time is usually the next business day after it's been received. That's why we are restricting the lab testing that we're doing here at the lab for those cases that are either most severe or that have some actionable public health consequences. There's a question about, can you expand on setting up telehealth visits and kind of how do you do that? How does it get reimbursed? That is not an area of expertise of mine. One thought that I had around that is if you're not already doing telehealth, now might not be the best time to think about starting. But it's certainly a great tool that if it's already part of your practice, to think about how you would use that. There's a question about what is the time frame from exposure to active symptoms. So effectively, that would be an incubation period. So the incubation period for SARS-CoV-2 is somewhere between 2 and 14 days. That is why we had landed on the 14-day quarantine period that had been instituted during containment. So we don't really know. I know that's kind of a broad range, but 2 to 14 days is kind of what we're working with. So if you are a provider that does not have PPE, you have someone who walks in with symptoms of COVID-19, again, remember, Transmission of COVID-19 does require that close contact, so think about that 6 feet. Maybe think about that when you're thinking about where your office staff sits and how you do that initial triage of patients. If you are really not capable of doing the triage and what may be necessary testing because of a lack of PPE, then you should safely refer that patient elsewhere. And then also think about if you don't have the ability to contain that person's droplet secretions, think about how you are planning to do environmental cleaning following that person being in your facility. And again, a lack of PPE is information that we're actively collecting from our from community providers through local health departments so that we can provide PPE as requested. So there's any recommendations for urgent care regarding testing. Our current protocol is to send any COVID-19 to the ER. So again, we would appreciate you kind of reconsidering those protocols and recommendations for a patient who doesn't require a higher level of care. So based on their symptomatology, if you don't think that they're going to need to be evaluated to be admitted to the hospital, referring them to the emergency room is probably not the best place for them to go. Again, COVID-19 testing can be obtained in the community. We are working on additional sites outside of our traditional practices to obtain that testing. But for now, you can refer them either to their primary care provider who might be able to do that testing, or if this is your urgent care, I would strongly have you consider how you might be able to implement this in your own practice, as it's not really beyond your scope of practice. There's a question about whether we're going to do another webinar regarding for healthcare workers. So we are recording this webinar. We will be posting it to our website. We highly recommend that if you have colleagues who would be interested and could learn from this, that you direct them there. At this time, we don't have plans for another webinar, but things change day to day, so stay tuned. All right, and with that, we have reached the end of the hour. I really appreciate a lot of good questions and your attendance here today. We here at the Arizona Department of Health Services really appreciate all the work that you are doing out there in the community. We want to partner with you, and we want to make our response to this a success. So please continue to look to our website for further guidance and instructions. Sign up for azdhs, grab our app, and we hope to stay in close contact. So thank you very much.